Let's talk about muscular dystrophy by introducing a case. A 4-year-old boy is seen by his pediatrician because of difficulty walking, climbing stairs, and clumsiness. According to his parents, he began walking at 14 months of age, but in the past year began to fall more frequently and experience difficulty getting up from the floor, having to use his hands to climb up his legs. The birth and developmental history were unremarkable. On physical examination, he had significant weakness of his hip flexors, knee extensors, deltoids, and biceps muscles. His calves were large but had doughy texture, and he walked on his toes. A dramatic Gower sign was present, and the serum creatinine kinase was 1500 IUs per liter. Introduction. The muscular dystrophies are a large group of inherited disorders of muscle in which patients suffer from progressive muscle weakness and degeneration and death of muscle fibers. With dramatic advances in basic neurosciences, it has become clear that the underlying abnormalities in the muscular dystrophies involve structural proteins of the muscle cell membrane, the sarcolemma, or proteins that bolster the membrane through attachment to elements of the muscle cell cytoskeleton and extracellular matrix, or ECM. The most well-known and most common of these disorders is Duchenne muscular dystrophy, or DMD. The molecular defect in DMD was discovered in 1987. The defect involves a large rod-shaped structural protein named dystrophin, and dystrophin is normally found in the region of the sarcolemma. The diagnosis of DMD, even in this molecular era, still depends on careful observation and clinical suspicion before a caregiver embarks on laboratory investigation to rule in or rule out the diagnosis of this progressive disease that is uniformly fatal. Now moving on to the muscular structure and function. Skeletal muscle is made up of bundles of long, up to 30 centimeters, cylindrical cells, or 10 to 100 micrometers in diameter. These units are called muscle fibers and contain multiple nuclei occupying a position just below the cell membrane. The plasma membrane is electrically excitable and is called the sarcolemma. Surrounding the myofibrils is a sarcoplasm, or muscle cytoplasm, containing large amounts of glycogen and creatine phosphate and lesser amounts of ATP. Red fibers contain many mitochondria for carrying out oxidative phosphorylation. White fibers are predominantly glycolytic. And just as an aside here, let's talk about the red and white fibers. The red fibers are type 1, and these have a sustained contraction. They're also known as the slow twitch fibers. They're half the diameter, 3 times slower, and they're aerobic. And aerobic because they have more mitochondria and myoglobin. On the other side, you have the white fibers, type 2, and these are involved in hypertrophy. They are fast twitch fibers. They are large and are anaerobic, and these are what you would find in most skeletal muscle. They need glycogen but not oxygen. They are anaerobic. So moving on, we'll talk about myofibrils. Each muscle fiber is filled with hundreds of myofibrils, 1 to 2 micrometers in diameter, running parallel to the long axis of the muscle fiber. By electron microscopy and chemical analysis of the fiber constituents, it has been established that the thick filaments in the figure are made of myosin, while the thin filaments are made up of actin, tropomyosin, and troponin. The thick and thin filaments interdigilate in a manner reminiscent of a partially shuffled pack of cards. So once again, the thick and thin filaments interdigitate in a manner reminiscent of a partially shuffled pack of cards. The thick filaments comprise the myosin-rich A bands, and actin and its regulatory proteins form the less dense I bands. When examined by EM in transverse section, each thick filament is surrounded by 6 thin filaments deployed as a hexagon. Now let's consider the sliding filament model in contraction. When a muscle contracts, the thin filaments slide over the thick filaments so that the Z lines move closer together, and while the A bands draw closer together, each A band maintains its length. The sliding is powered by an ATPase that is part of the large myosin molecule. Depolarization of the skeletal muscle membrane triggers release of calcium from its storage sites in the sarcoplasmic reticulum. Calcium binds to tropomyosin C, causing troponin and tropomyosin to move out of the way, allowing actin and myosin to interact. In a sense, tropomyosin is a chaperone, preventing actin and myosin from sliding past each other until calcium levels rise. The dystrophin glycoprotein complex, the inherited defect accounting for DMD, and the milder variant Becker muscular dystrophy, or BMD, involves the structural protein dystrophin. The contractile proteins connect to the basal lamina, or basal membrane, and the ECM through the dystrophin glycoprotein complex. Dystrophin is located in the cytoplasmic inner face of the muscle membrane. The large 427kDa rod-like protein is a structural protein with homology to spectrin, a key membrane protein in the red blood cell. At its amino terminus, dystrophin binds to the actin filament, and at its carboxy terminus, dystrophin is linked to two glycoproteins, the dystroglycans, that forge a link between dystrophin and laminin, a structural protein in the basal lamina. All told, the dystrophin glycoprotein complex is comprised of dystrophin, the dystroglycans and sarcoglycans, and the alpha-2 chain of laminin, also known as merosin. So laminin is called merosin. Defects in the sarcoglycans have been demonstrated in some variants of limb-girdle muscular dystrophy. Thus, a defect in any one of the components of the dystrophin glycoprotein complex, or DGC, can lead to a variant of muscular dystrophy. It is widely believed that the DGC buffers the cell membrane from the mechanical stress of muscle contraction. In the absence of any of the protein comprising the DGC, muscle damage and necrosis outpace the repair and regenerative capacity of the affected muscle. Now let's discuss the clinical manifestations. DMD is the most common hereditary muscle disease, with an incidence of 1 to 3,600 live-born infant boys. DMD is inherited as an X-linked recessive trait, and no race or ethnic group is immune. Absence or deficiency of dystrophin is the inherited defect encoded by an extremely large gene of greater than 2.5 million BP and 79 exons or coding regions found on the small arm of the X chromosome, XP21. BMD is also caused by a defect in dystrophin, but in this disease there is decreased or abnormal dystrophin that retains enough function to have a milder course, with a slower rate of deterioration of function. So Becker's is not as serious as Duchenne's. Infant boys are usually asymptomatic in early infancy, but after learning to walk sometime after 12 months of age, the clumsy gait of the toddler does not improve. The telltale sign of the hip girdle weakness, the need to place one hand on a knee and climb up the leg to rise from the floor to an upright position, which is called the Gower sign, may be present by 3 years and surely by age 5. Lordosis becomes obvious and the child waddles when walking. Pseudohypertrophy of the calves is another important sign, but requires palpation to confirm that it is fat and not muscle. Palpation to confirm that it is fat, not muscle. There is also wasting of the thigh muscles. One can imagine the devastation for parents and child when the diagnosis of DMD is entertained, and again when it is confirmed. Eventually the child will become wheelchair bound. It is vital to prolong ambulation, often with orthopedic bracing, physiotherapy, and sometimes lengthening of the Achilles tendon, not only because it maintains personal independence, but because scoliosis becomes a major complication once the patient is confined to a wheelchair. Because proximal muscles are affected more severely than distal muscles, the patient is usually able to feed himself with eating utensils and use writing instruments and type at a computer keyboard. Weakness of the respiratory muscles renders the patient liable to bronchitis and pneumonia, and over time pulmonary reserve declines. Because dystrophin is expressed in cardiac muscle, 50 to 80% of patients develop cardiomyopathy manifested as increased heart rate and development of heart failure. Periodic electrocardiography, echocardiography, and radiography of the chest and evaluation by a pediatric cardiologist are all recommended. Most patients suffer intellectual impairment with a mean IQ of 85. The mental impairment is not progressive. These patients can function in a regular classroom setting with remedial help. In the past, death usually occurred by age 20 years, with the use of glucocorticoids which delay progression of the muscle deterioration and necrosis. Selected patients are surviving to their late 20s and early 30s. Death is usually attributable to sleep apnea, heart failure, pneumonia, and occasionally aspiration with obstruction. Becker MD, in contrast to DMD, proceeds at a lower pace, with boys remaining ambulatory until late adolescence or early adulthood. Diagnosis: serum creatinine kinase levels in DMD often exceed 15,000 international units per liter, almost 100 times the normal range. No other muscle disease is associated with such striking elevation of creatinine kinase. Indeed, if creatinine kinase is not greatly elevated, some other myopathy must be considered. This is important, so I'll repeat it. Serum creatinine kinase levels in DMD often exceed 15,000 international units per liter, almost 100 times the normal range. No other muscle disease is associated with such striking elevation of creatinine kinase. Indeed, if creatinine kinase is not greatly elevated, some other myopathy must be considered. In light of the prognosis and long-term care implications of a diagnosis of DMD, the first diagnostic test is the polymerase chain reaction, or PCR, for the dystrophin gene mutation. But because approximately 30% of patients do not show an abnormality with PCR, immunohistochemical staining of frozen sections of muscle biopsy tissue will reveal defective or absent dystrophin. Pathologic findings on muscle biopsy show connective tissue proliferation and scattered degenerating and regenerating myofibrils. Regarding the genetics, although DMD is transmitted as an X-linked recessive trait, in approximately 30% of patients there is a new mutation in the fetus, the mother not having transmitted the defective gene. Female carriers are usually clinically normal, but rarely because unequal lionization, the normal X chromosome is inactivated, and the X bearing the dystrophin gene mutation is expressed. In fact, several girls with Turner syndrome, XO, have had full-blown DMD because their single X chromosome expressed the gene deletion for dystrophin. Pathogenesis. The dystrophin glycoprotein complex shores up the sarcolemma of skeletal muscle cells in an elaborate network of structural proteins. The network is believed to function as a shock absorber, to cushion the stresses imposed on muscle during the seemingly endless rounds of contraction and relaxation. However, confining the action of the DGC to only a structural role in the pathogenesis of DMD may be too simplistic. Indeed, there is now abundant evidence that the membrane damage that occurs in DMD is associated with increases in intracellular calcium. The increased calcium activates calcium-dependent proteases, including the calpains, which carry out proteolysis of muscle fibers, including further damage. The presence of enormously elevated CK levels, or creatine kinase levels, in serum reflects damage to the sarcolemma and leakage of the enzyme into the blood. Recently, a defect in a protein called dysferlin that mediates membrane repair has been found to be deficient in limb-girdle muscular dystrophy. Thus, there is evidence that in addition to the undoubted structural abnormalities associated with defects in DGC, there are very likely signaling abnormalities that further exacerbate the muscle damage, hastening necrosis and, in some instances, apoptosis. Management. Because the implication of a diagnosis of DMD is so profound, confirming the diagnosis is an essential first step by testing a blood sample to define the nature of the DMD mutation. Even if a muscle biopsy has demonstrated absence of dystrophin. Let's repeat that. Because the implication of a diagnosis of DMD is so profound, confirming the diagnosis is an essential first step by testing a blood sample to define the nature of the DMD mutation, even if a muscle biopsy has a demonstrated absence of dystrophin. Defining the nature of the mutation provides vital information for genetic counseling, prenatal diagnosis, to prepare the family, and to provide the potential future mutation-specific therapies. This testing must be undertaken in a laboratory with considerable experience. Indeed, the diagnosis and management should be carried out under the auspices of a multidisciplinary center for muscle disorders. Once the diagnosis of DMD is confirmed, it is possible to develop a regimen to improve function, quality of life, and the longevity of these children and young adults. This program includes the use of corticosteroids and attention to respiratory, cardiac, and orthopedic complications. Rehabilitative interventions can greatly ameliorate the lot of these patients. There are now patients surviving into their fourth decade of life. Glucocorticoid, and we're talking about prednisone therapy, is the mainstay of pharmacologic treatment of DMD. Prednisone decreases inflammation, prevents fibrosis, fosters muscle regeneration, slowing decline in muscle strength, decreases formation of reactive oxygen species, and inhibits signaling pathways that lead to apoptosis. But glucocorticoids have a host of unwanted side effects, among which is osteoporosis, which is further exacerbated in the wheelchair-bound patients. Patients to be started on steroids must have childhood immunization, including varicella, before embarking on therapy. Experts recommend holding off on steroids until the child is no longer showing progress in motor skills. Starting too soon only heightens the potential for adverse side effects. Attention to psychosocial needs of the patient and his family are also important because depression often arises in the setting of chronic progressive diseases like DMD. Consultants in orthopedics, cardiology, pulmonology, and psychology should be members of the multidisciplinary team. Consultants in orthopedics, cardiology, pulmonology, and psychology should be members of the multidisciplinary team. Emerging therapy for DMD, antisense oligonucleotides and exon skipping. Eukaryotic mRNA is transcribed from DNA by RNA polymerase II into a temporary precursor molecule that is much longer than the final mRNA transcript. This is because the final transcript is made up of express sequences called exons, which have been spliced together after removing intervening sequences called introns. A large complex of proteins and RNA called the spliceosome, carries out the precise splicing of the exons to generate the final mRNA that encodes a particular protein. Recall that this mRNA leaves the nucleus entering the cytoplasm where it binds to the ribosome where protein synthesis or translation occurs. Earlier we discussed that dystrophin is a large protein, 427kDa, that is rod-shaped with two binding domains at either end of the protein. The domain at the amino terminus binds to actin, and the domain at the carboxy terminus binds to dystroglycan. It appears that preservation of these two binding domains at each end of the protein will allow a dystrophin molecule shortened by mutation to still fulfill its scaffolding function by binding to actin and dystroglycan, but such a shortened dystrophin may be less efficient as a buffer against stress at the sarcolemma because it is truncated. In fact, this is what is believed to occur in some patients with DMD, the milder, more slowly progressive form of muscular dystrophy. In contrast, in DMD patients, the dystroglycan binding domain is lost because a mutation changes the reading frame, resulting in a premature stop codon, which produces a shortened protein devoid of the dystroglycan binding domain. The genetic code consists of an overlapping triplet code without punctuation, so that the DOD can run and it must be starting. In this example with T, if instead translation begins with the H, a different set of triplets will be read. Normally, mRNAs can be read in only one reading frame because stop codons would likely be encountered in the other two possible reading frames, causing translation to terminate prematurely, producing a shortened, functionless DUD or DUD. The idea behind exon skipping is that by hopping over one or more non-essential exons in mutated dystrophin that harbor a stop codon, the reading of mRNA can continue so that the dystroglycan binding domain is again expressed, albeit on a shortened protein. What antisense oligonucleotides or AON do is to bind to an exon in the middle of the dystrophin mRNA, thereby hiding it from the splicing machinery. If the spliceosome does not recognize the blocked exons, the spliceosome skips over the blocked exons and continues splicing out introns and joining exons behind the site blocked by the AONs, the AONs. The goal of such therapy is to synthesize a partially functional dystrophin, as found in BMD, converting the severe BMD phenotype into a milder BMD form. Okay, finally, in a comment on this case, a muscle biopsy revealed variation in muscle fiber size with increased connective tissue between the fibers. Immunohistochemical staining for dystrophin revealed absence of that structural protein. PCR testing confirmed a deletion within the dystrophin gene. The boy has been referred to a multidisciplinary muscle clinic to coordinate the various aspects of his care. The decision to start prednisone will be made by the neurologist when it is determined that his motor skills have begun to plateau. The parents are seeing a psychologist to deal with their grief.